Are you ready? Yes. Alright. Hello. Alright, so today we're going to talk about some vasopressors. And we will just go over them generally, and then we'll dive on titration and any specific questions that you might have. Sound alright?
Mm-hmm.
Alright, so the most popular that you're going to see is Levophed, norepinephrine, right?
Mm-hmm.
So Levophed has a little bit of beta-1. Anybody know where beta-1 is?
In the heart.
Uh-huh. And what does it do if I activate beta-1?
It excites it.
Excites it. What does that mean?
Increase.
Increases
Contractility of the heart.
Good job. And heart rate.
Yeah. Yes.
So you got like an increase of force of contraction, and you got an increase of heart rate, right?
Mm-hmm.
Beta-1. Whenever all alphas and betas are sympathetic, so activating that, you think about if a bear walks in, that's what we're activating. And when a bear walks in and we're activating beta-1, we're talking about increased force of contraction and heart rate, right?
Mm-hmm.
It also has alpha-1, which is, anybody know? I drew it over there. It's kind of vague.
I guess. I don't know.
It's confusing. So that's your arteries, right?
Uh-huh.
So it's your vasculature. You have alpha-1 in your peripheral vasculature. And if you activate that, it vasoconstricts, and up goes the pressure, or the blood pressure, right? So increase blood pressure by increasing systemic vascular resistance. So it increases blood pressure by both the heart rate and SVR, and we'll leave it at that for right now. We'll say neo is alpha-1. That's it.
Mm-hmm.
Okay, so it's selective. All right. Vaso is different. It's more confusing. Vaso is an antidiuretic hormone, so you can tell automatically that it has an antidiuretic effect, but it also binds to these vasopressin receptors, and it causes vasoconstriction, which really, we're going to say, increases SVR, right?
Mm-hmm.
Systemic vascular resistance. Similar to the neo, works in a different way. Cool thing about vaso is it retains some or more of its properties of increasing blood pressure during acidotic states than others. Okay? All right. Epi. So epi, we have same thing as levo, beta-1 and alpha-1, except the beta-1 is greater than the levo. So you can see increased heart rate with levo. I'm sure you've all seen it before.
Mm-hmm.
But with epi, you can see more of an effect on the heart rate. Okay? So it's binding to alpha-1 just like levo, and it's binding to beta-1, except it hits it harder. So dopamine is a little weird because it depends on the dosing. We have like a low dose that binds to these dopamine receptors, like a medium dose and a higher dose. So we're going to ignore the low dose. It has to do with like renal perfusion. We're going to focus on the medium dose, which would be like a beta-1, and the higher dose would be like an alpha-1. So we've got similar effects as levo.
Backtrack. Sorry, I just don't want to miss anything.
Yeah.
Beta-1 more cardiac muscle. Alpha-1 more vaso.
All vasoconstrictions.
All vasoconstrictions, but beta-1 is
It's
more
only.
targeted.
So
it's
whenever-
only targeted cardiac.
I mean, there's different distributions of some of these, but for the most part, we're going to say that beta-1 is on the heart,
Mm-hmm.
and alpha-1 would be on the vasculature,
Okay. I just don't want to lose it. Mm-hmm.
right? So if I give neo, for example, I'm only hitting this right here, and I'm not hitting this up here,
Okay.
which will come into play in just a second.
Say that again. Say that one more time.
So if I'm giving neo a selective alpha agonist, so it's activating alpha-1, I'm only hitting this alpha over here, and I'm not getting any beta.
Good.
Okay.
And that's normally why Neo is not your first line mechanism for low
For
blood
sepsis.
pressure.
Yeah, so they've done some studies, and they've pitted levo and dopamine and some other things, and it turns out that levofed has better outcomes, and we can talk about that compared to some of these other pressors, and that's why it's first line therapy for sepsis. There are certain circumstances that you might choose Neo, and we'll talk about that. But dopamine is kind of like levo. The low dose is different because it's renal perfusion, but middle dose is heart rate, right, beta 1, and as you go up higher, it's more and more vasoconstriction with the alpha 1. Okay? And the Ang2 is different too. It's in the name, angiotensin 2. So it binds to these AT2 receptors, and which is associated with your RAS system. So it's going to be increasing your RAS, increasing norepinephrine release, aldosterone, all the things. And you really see mostly an increase of SVR. I think the heart rate is not a big player there. Okay? This is the newest one. It's the most expensive. Second most expensive is vasopressin. All right, and I put these over here because these do have, this is a non-selective, so we got beta 1 and beta 2. And then this one is like a PDE inhibitor. PDE inhibitor. So they work a little bit different. Obviously, dobutamine, we talked about beta 1, right? Increasing heart rate, force of contraction. You see the theme over here. But now we got a beta 2. I don't know, I'm going to draw. So this person's got big. That's my big muscle right there. Big muscle. This is where beta 2 is on your vasculature. It's on your muscles. And actually what this is doing is vasodilating. So it vasodilates, which can decrease SVR. So these two might fight a little bit in your overall blood pressure. On one end, you're increasing cardiac output. These are ionotropes, which increase cardiac output. But on the other hand, it's vasodilating your vasculature and your muscle beds, which might drop your SVR. So you could see an increased blood pressure if the beta 1 is overpowering the beta 2 effect, or you could see no change, or you could see a drop in blood pressure. But you would be able to explain it by knowing that, well, if my blood pressure is dropping, even though I'm going up in my dobutamine, it's because I'm getting a lot of vasodilation here. Does that make sense? And the milrinone is different too. It works by inhibiting these phosphodiesterase that are specific to your heart, and it increases cardiac output by heart rate, force of contraction, cardiac output, and it can also have a side effect of decreasing SVR. So it too can cause similar effects of increasing cardiac output, heart rate, and all these other things. The heart rate's usually not increase as much as the force of contraction, but if you start to accumulate it because you don't really dose it correctly, you can have tachyarrhythmias. Okay, so this is just the basics, right? You have to ask yourself, why did levo have certain outcomes, right? Why would I choose levo over dopamine, if they both, or epi, right? So these are some of the debates that go on. And some of the studies have shown that levo has favorable outcomes to dopamine. And why is that? Because dopamine hits the beta 1 harder than levo on average whenever you're going up to those vasopressor, this vasoconstriction, and you can cause more tachyarrhythmias, right? So you could ask yourself, when would you want to use dopamine? When the heart rate is low, right? And the blood pressure is low, so you want to increase both. You would get more beta 1 than levo in that situation. So if you have a bradycardic patient who's also hypotensive, you might see the physician ordering a dopamine because they want that increased heart rate from the beta 1. Okay? What you got?
Question. So, I remember, I don't know if this is for vasopressin. There was always an inverse, or I might think about something else. Inverse relationship. I thought there was always an inverse relationship between blood pressure and
Cardiac output?
yeah.
So, not exactly. You can have, I don't know if I should write it out, the whole thing of cardiac output equals like stroke volume times
I don't want to go
heart
that
rate.
deep.
Right? But what
Yeah.
I'm saying is, say, if we're talking about cardiac output, obviously these are going to increase cardiac output because you have increased heart rate, force of contraction, right, is blowing out more volume, faster, you know, and the SVR is going down and not going up. There is a balance over here with levo, right, in some of these, where you're going to have increased SVR, but you're going to have increased heart rate and force of contraction. So on one hand, you have this increased SVR, stroke volume, but you're having an SV, whatever. But you have an increase afterload, right? So you're fighting the actual cardiac output.
Yeah.
You know what I mean? So you could see like the SVR here overpower the beta 1 effect, and you have a decreased cardiac output in this situation. Whenever you might have like a balanced cardiac output in epi, where it might be like equal, you know, and each patient might vary a little bit differently. You know what I mean? If you're only like a middle dose of this